Hello everyone. Today we shall go through a very interesting connective tissue disorder, a disease we call dermatomyositis, also called the Wagner-Universitsch syndrome. So in this case, we want to discuss this condition in detail, such that we know that how do you look for it, what signs do you elicit, and how do you know that your patient has dermatomyositis. I'm Dr. Abraham from A&E Dermatology Specialist Uganda, and I welcome you to this lecture. So in the picture that you see here, we see a rash on the hands. We see some splinter hemorrhages here and loss of or ragged cuticle here. We see a rash on the back here. Then we also see a rash on the thigh. So when you look at the animation is also still showing you a rash around the eyes, a rash in the neck, a rash on the hands, as well as muscle weakness, and also papules. So don't worry, we're going to look at the details of each. So in your body, we have what we call connective tissues. That includes the ground substance. It includes your muscles. It includes the fascia, and all these connective tissues can get disease. So one of them is dermatomyositis. So dermatomyositis is also called the idiopathic inflammatory myopathies, or also called the idiopathic inflammatory dermatomyopathies. So when you hear the word dermatomyositis, just remember it has derma, which means skin, and then also it has myo, which means muscles, and then sitis simply means inflammation. So in this condition, you are having inflammation or skin lesions, you're having inflammation in the muscles, and that constitutes the component of this condition. So how common is it? It is one of the rare autoimmune conditions characterized by muscle weakness and also skin rashes, just from the word derma, skin, myo, muscle. So it has different types, whereby the classical type will be the one we've talked about, inflammation affecting muscle and skin. But sometimes you can have dermatomyositis, whereby the skin has rashes, but the muscles are okay. So that is what we call dermatomyositis sin, myositis, meaning sin just means without. So dermatomyositis without inflammation of muscles, or what we call a myopathic myositis. So in this case, you don't have muscle involvement. You can also have dermatomyositis where you have the skin not affected, but the muscle affected. So that's dermatomyositis sin dermatitis. So the skin looks normal, but the muscles are affected. So this table here tries to categorize and classify for you the dermatomyositis, and this just tries to group all this the same disorder, just looked at differently. So you can look at it in terms of onset, where it will either be adult onset or juvenile onset. So under each of these, it can either be the classical. Now the classical is the one where you have inflammation of both the muscle and a skin rash. Then we can have also the classic, but in this time round, it is occurring concurrently with a malignancy. Or you can have the classical dermatomyositis, but occurring or overlapping another connective tissue disorder like systemic lupus erythematosus or any other systemic connective tissue disorder. But as well, you can also have the dermatomyositis without muscle involvement, or what we call the amyopathic dermatomyositis. And in this case, it can either be complete muscles affected or just reduced muscle function. So the hypo means reduced myopathic dermatomyositis. The muscles are affected, but not to a greater extent. And then the classification under juvenile, it will still be either the classic type or the clinically amyopathic dermatomyositis or hypomyositis. Myopathic, you know, every time you add a in front of a word, it makes it a negative. Myopathic, so that means that without muscle involvement. Then hypomyopathic, slight muscle involvement. Then the other classification gives us the polymyositis. In this case, the skin is okay, but now you have isolated involvement of the muscles. So the other last one is the inclusion body myositis, which is usually covered in other disciplines. So how common is the dermatomyositis? When you're looking at the epidemiology or how common this disease is and how it is distributed, you'll find that it has two forms, the adult form we've talked about and then the juvenile. So the adult form usually peaks around 50 years and most commonly in women than men. And what you have to remember at least is that all the connective tissue disorders, most of them, they are more common in women compared to men. However, the juvenile type loves occurring between the age of 5 to 10 years, and it is one of the most common inflammatory myopathy seen in children. So, when you look at the pathogenesis, how does the dermatomyositis come about? So in this case, it has been thought or postulated that the primary process is actually an inflammatory attack on endothelium of the capillaries of myofibers. So in this case, you have a muscle, for example, if I'm to draw here, you have a muscle, if this is your muscle, you know, muscle usually have a little bit of fibers. This muscle is usually supplied by a blood vessel. So if this is your blood vessel supplying that muscle, so now the immune system will come and attack the endothelial cells of this blood vessel. So when you attack the endothelial cells of this blood vessel, usually by deposition of complement, you know the complement system, you have formation of complement along the blood vessel. Then at the end of the complement system, we usually form what you call MAC or the membrane attack complex, then you destroy the endothelial cells. So when you damage now the endothelia of these blood vessels, that means that the muscle that they are supplying will have no more blood supply, no nutrients. What happens in that case? The muscle will become atrophic. So this usually causes perivesicular inflammation, and then eventually you have to reduce the number of the blood vessels that are supplying the muscles. So because of this, the blood vessels are low, they are not supplying blood and the nutrients, then you cause hypoxia. Hypoxia damages the muscle fibers themselves, and then they end up with atrophy, or you lose those fibers that are not supplied. So at the end of it all, someone progressively loses muscle fibers on a daily because of continuous inflammation that targets the endothelium of the capillaries that supply the myofibers of the muscle tissue. So this is a chronic disease, and the number of capillaries can be significantly reduced when you take off even a biopsy. So you take off a biopsy and you see that the blood supply to the muscle has been significantly affected. And when you do molecular studies, you'll find that there's usually a upregulation of the MHC class 1 on the myofibers and increased expression of the ICAM. So this is the more of molecular biology, but what you have to understand here, as simple as it is, you have a muscle supplied by a capillary. Now the immune system attacks the capillary endothelium of that blood vessel supplying the muscle. So since the muscle has no blood, it undergoes atrophy. So there has been no any viral etiology associated to dermatomyositis. So the exact cause is actually up to date, not known. We don't know how this disease comes about, causes it. However, in the juvenile type, it has been associated with particular genes, especially those children who have human leukocyte antigen, the QA10501. They have a higher risk of getting this condition, but not that all of them have, but this is the genetic predisposition that has been associated with dermatomyositis. The adult form, most of them, there's a 50% chances of them having an underlying malignancy. So there's a thought that maybe because of the malignancy that the patient has, then you have these stray autoantibodies that end up attacking the endothelial vessels of capillaries that supply the muscle tissue. So there has also been an association of dermatomyositis with other connective tissue disorders like systemic lupus erythematosus, systemic sclerosis, and then mixed tissue disease. So when you look at the clinical feature or seen in dermatomyositis, we know that we have the muscle and the skin. So if it is the muscle affected, someone will have muscle weakness, which usually affects the proximal muscles, that is the arm, and the thigh muscles are the ones that are usually affected, together with the shoulder, hips, and then also the neck. However, muscles within the distal parts of the body, that is the forearm and the legs, are usually spared. So they also usually get generalized fatigue because, if your muscles are not working well, you usually get tired easily. So that's the fatigue where that's why it comes about. But then on the skin, we have particular presentations that we usually see. So the first one is what we call the heliotrope rash. Heliotrope just means loving the sun, like helicopter. So heliotrope. So this rash is usually a violaceous rash seen on the eyelids, and we also have what we call the Gottron papules, which I will see them in the picture. So these are usually red papules, which are usually seen on the knuckles. And then we have what we call the shawl sign. So the shawl sign, a shawl is that piece of clothing that people have to put around their neck. So the rash follows that pattern. So if it is on the chest, neck, and back, like we see in this picture here. So if the rash comes all the way up to here, so that is a positive show sign. But if the rash is only in the chest, maybe the other side, for example, in this animation here, if the rash only stops here, that becomes the V sign. But if it's covering all the way down where the shawl covers up to the back and around the shoulders, it becomes the shawl sign. And then we've said that they usually have proximal muscle weakness. And then these are the Gottron papules that are usually seen on the hand. So that's what we are seeing here. If you can see now where my cursor is in figure number A. So we usually also have rugged cuticle, which is usually around here. And then also in this picture, we see the heliotrope sign, which is usually periorbital swelling and appearance. So when you look at the different sites where we see these features, usually the muscle weakness is symmetrical, affecting the proximal limbs, and the weakness is usually progressive, and it occurs over weeks to months. So someone will complain of proximal weakness over a long period of time. And we've had some few cases where the onset is a little bit more acute than in others. And the patient will describe for you that they feel difficulty when they're either getting up, raising their hands over the head, maybe when they're showering. Those movements that involve using the proximal muscles become a problem, like climbing stairs, lifting objects. So when you hear such an history, you have to think about dermatomyositis. And the distal weakness is generally not present. So someone will have normal grip, normal flexion at the ankle joint and the wrist joint. But when you look at the arms, there is usually wasting and then muscle weakness. So the classical symptoms, usually we've said that the rash is followed by a mild or to severe myopathy, and depending on the degree at the time of presentation, you can either have with muscle involvement or even with skin involvement or both or one of them just. So depending. So and then we've said there's that helicotropic rash, which is usually, I've told you that helicotropic simply means something that moves towards the sun. So the rash, will see it like on the eyelids, you will see it on the sun exposed areas, like the chest, the neck, the shoulders. That's where the rash will have most. And then we've said that the V sign is when the rash is on the chest, and the shawl sign, we've said that one when the rash covers all the way back up to the shoulders. Then we've said that the Gottron papules was usually elevated purple rash that as seen on the metacarpal joints and also on the dorsal surface of the hands. Then the Gottron sign, usually someone has erythema on on the dorsum of the hands, elbow, knees. That is the Gottron sign. So the Gottron papules different from Gottron sign. And occasionally, these patients can have an idiopathic interstitial lung disease. So when you have a patient with dermatomyositis, it is prudent that you also screen them for a possible interstitial lung disease. So this is what we've been talking about. So you see this periorbital swelling and erythema, that is the heliotrope sign. And you see these papules usually on this metacarpal joints. So it can also be this erythema covering all the way down to the on the dorsum of the hand, all the way. It can also affect the elbows as well as the knees. So that is the Gottron sign. But when you see the papules on this joint, it becomes the Gottron papules. So like here, now these ones are papules. All right. So the cutaneous manifestations in dermatomyositis are very, very many, and we've talked about almost all of them. I'll just highlight when it comes to the nail folds, they usually have a ragged cuticle that I've shown you in the animation previously. So that ragged cuticle, take note of it. And we've said that this rashes usually love the sun exposed areas, and that's why they'll end up with a photo distribution. And also they love the extensors of the body. That's the extensor surface of the hands, the knuckles, elbows, and knees. And this may make you think about psoriasis, because psoriasis typically morphologically loves those areas. So when you go to the scalp, if the lesions involve the scalp, they may look like seborrheic dermatitis, and sometimes they are a bit very pruritic. And in addition to cutaneous features that we've seen, in some cases, we can have patients also having calcinosis cutis. That is usually calcium salts that have calcified under the skin, and it is also a feature that can be seen. So sometimes they can also have Raynaud's phenomenon. So if you have calcinosis cutis, Raynaud's phenomenon, esophagitis motility, then it becomes crest syndrome. So you take it to the other side. So the less common mucocutaneous features, we have things like if the disease is severe, you can end up with erosions and ulcers. You can have patches around the thighs, which we usually call the holster sign, the one that I showed you here, if we are to go back. So this one, this rash on the lateral sides of the thighs, we what we call the ulcer sign. You know that those Mexican cartels that usually have guns, and they have in that casing that is called a holster. So that casing is usually on the lateral side of the thigh. So that's where the rash is located. And when you see that, you have to suspect dermatomyositis. So how do we make the diagnosis? Usually the diagnosis is the correlation between the clinical picture that you see with the patient together with the pathological or pathologic finding when you take off a biopsy and you examine the muscle fibers. So when you're taking off the biopsy, you take off both the skin and the muscle. So you want to look at the muscle and see if it's, the muscles are affected. So depending on which muscle you're targeting, so you can take off fibers from the muscle of the biceps or tricep, or any muscle from the thigh. So the other studies that can be done, you can also do the nerve conduction studies, and these ones usually you want to see how the muscle contraction responds to different stimuli of electricity, and then you can now determine that the power is reduced or more depending on what you get. So in the laboratory, you can look out for creatine kinase. You know that when you break down muscle, you produce a lot of this enzyme in circulation. So if it is 5 times to 50 times the normal, then you have to suspect that there's increased muscle breakdown. So you have to look for conditions that cause muscle breakdown or wasting. Another enzyme that can be assessed as well is aldolase. It also usually releases when you break down a lot of muscle tissue. So you can also find antibodies, autoantibodies, which are associated with other connective tissue diseases. And in this case, they may not be specific for dermatomyositis. So things like ANA, we've seen it positive in SLE. So in the juvenile form, you can see it being also positive as well. And then the antigen antibodies are usually common in the adult forms. So this table tries to summarize the different autoantibodies that can be used to screen for dermatomyositis, and you find that most of them, they're not very specific. So you see them in other conditions, but when you see them, at least you suspect an autoimmune process ongoing. So the first one is the anti-amino acyl transfer RNA synthetase. And in this case, these are the enzymes that you can detect the antigen. We've seen the antigen being commonly seen in adult patients, but even only up to 20% of patients always have this positive. So you may find yours being negative. That one doesn't necessarily rule out dermatomyositis. So we also have the anti-M2 antibodies, and then in this case, we usually see them in the and being more classic or seen commonly in the classic dermatomyositis. And when you see them positive, usually it is a good prognostic factor because patients usually will respond to your treatment. That is the anti-M2 antibodies. Other antibodies that can be detected with the anti-TIF1 or the anti-155/140 140 antibodies, and in this case, they have been seen in severe cutaneous or malignance associated or amyopathic dermatomyositis, but not in all cases. And the other one is the anti-MDA5. So this one has been seen in clinical amyopathic dermatomyositis, and usually implicates or seen in patients who get rapid progression to interstitial lung disease. So we also have other autoantibodies like the anti-NXP2. So this one is usually seen in the juvenile onset classic dermatomyositis. Usually, if a patient also has calcinosis cutis in the picture. Then the anti-SAE antibody. This one is also seen in the classical adult dermatomyositis, and they usually tend to progress to myositis and then also dysphagia. But in this case, the interstitial lung disease is a little bit uncommon. So all these autoantibodies, they look nice and nice to talk about, but the availability, affordability in our setting is still questionable. So that means that we base majorly on the clinical and maybe pathology findings. So your clinical should be well beefed up if you're to work in resource limited settings. So in the microscope, what shall we see? So when you take off a sample of the muscle fiber, remember we said that in this case, you're having a compromised blood supply to muscle fibers, and these muscle fibers will undergo atrophy. And we know that from your structure of the skin, the muscle fibers are usually separated by different fascicles or different septa, and that's where your blood vessels pass. So the muscle fibers that are usually near the septa are the ones that are affected first, and you see atrophy. So that is what we call the perifascicular atrophy, and it's the hallmark of dermatomyositis. So what you see here in the middle is the fascicular, or what we can call septa between the muscle fibers, right? And then these are the different muscle fibers. But you will notice that the muscle fibers that are near here are having atrophy, or they are small. Look at the size of that. Look at the size of that. And I want you to compare that with the picture that you see this other side. So the muscle fibers, this other side, they are big compared to the ones that are near the fascia or the fascicular side, so or the septa. So that is the hallmark of dermatomyositis. When you see that on the picture, you are right to make the diagnosis of dermatomyositis. That means that the blood vessels supplying the muscles near the septa are compromised first, and they will give you that atrophy. So that's what you will see on on that picture. So what are the different differentials like this man is asking in this picture? I love animations. So this man is asking what are the different things to think about if you have a patient with dermatomyositis. The first one is polymyositis, which is usually similar, but in this case you have all the muscles almost affected. First, there are those that are proximal. We had even a patient at the clinic where even the tongue muscles were affected. It was so bad that it impairs, you can't walk. The patient came walking after a few months of follow-up. The disease progressed and they were now in a wheelchair. And this is a very devastating disease. So you have to also think about other connective tissue disorders that can overlap with the dermatomyositis, including lupus, scleroderma, other myopathies, depending on the case, like other cases like the inclusion body myopathies. You have to think about them. So how do we treat dermatomyositis? The treatment, the first line is an anti-inflammatory drug because you know that in pathogenesis you have autoantibodies, so we give corticosteroids to help us reduce the inflammation, and then you can give all other immunosuppressive drugs, including azathioprine, methotrexate for long-term management. And this is a chronic condition, so when you start treatment and you have control over it, you have to continue that drug almost for life. So we have other strategies that try to rejuvenate muscles like physiotherapy. So this one tries to rebuild muscles and usually improves function. And then we know that this condition is made worse by the sun. So we do sun protection. So sun protection can be both physical and chemical with sunscreen, and then physical barrier like wide brim hat, long sleeved clothes, and the rest. And then the rashes can be treated topically by drugs that reduce inflammation like corticosteroid and corticosteroid sparing drugs like tacrolimus or pimecrolimus. So how is the prognosis? So in this case, the prognosis is variable depending on symptomatology and time of onset to the hospital. If someone comes early, you have better control of the condition and you can manage them easily. And if someone has malignancies associated, that complicates the picture and the prognosis may be not very nice. But what is important is that you have to follow up these patients for muscle strength, skin lesions for life, and the potential side effects of the medications that we're giving. Because we've seen that the drugs we give like methotrexate, azathioprine, cyclosporin, all those drugs have a lot of side effects, and the steroids as well. So you have to follow up, check the sugar, HbA1c, check the lipid profile, check the organ function all the time until when someone is called to heaven. But you have to make sure that you improve their quality of life when they have this condition. So the picture that we see here tries to show you the suggested screening in case you're suspecting any malignancy. You have to do urine analysis. You have to do stool occult to see if there's any bleeding in the GI. You have to do PSA to rule out prostate cancer. Then for women, you can do serum CA125, that is for breast cancer, hepatic cancer, and mammogram, CT scan, dependingly, colonoscopy, upper GI endoscopy, and the rest. So all these cancer screening tests are trying to make sure that your dermatomyositis is not influenced or is not due to any other underlying malignancy, because we say that in adult patients, 15% of them have an underlying malignancy. So this table here summarizes the approach. If you have an adult and you have maybe made a diagnosis or suspecting dermatomyositis, so if the patient has characteristic cutaneous lesions, then you have to take off a confirmatory histology, and in that case you'll see perivascular atrophy of muscle fibers. Then you have now to evaluate for myositis, that is involvement of the muscles, and that includes examination of the proximal muscles. You tell them to raise maybe their hand over the head. Then if you're in a better setting, you take off a muscle biopsy. If you're in a better setting, you can do electromyography to see the muscle fibers, how they're functioning, depending on the expected response. Then you can do MRI for proximal muscles to see the extent of damage, because the MRI is good with soft tissues. Then ultrasound scan as well can be done, and this is possible in our setting. Then after that, if someone has muscle involvement, then you are comfortable to make the diagnosis of dermatomyositis. And after making this diagnosis, then you can start systemic therapy. Then you can also evaluate them further for overlapping conditions as autoimmune conditions. So you'll be tasked to do the panel for autoimmune conditions, including SLE, connective tissue diseases like rheumatoid, arthritis, Sjogren syndrome, and the rest. So you have to screen all of them and as well evaluate all these patients for the malignancies that we've mentioned earlier. But in case you have evaluated here and then the muscles are negative, they are not, then you can presume that you are having a myopathic dermatomyositis. Remember, we say that in some cases you can have dermatomyositis without muscle involvement, or you can have dermatomyositis without skin involvement. So in that case, still you examine the patient and then start therapy. If the muscles are okay, then you start treatment for the skin lesions alone. But if later on the patient is followed up and then they develop muscle weakness, like in this box here, then you go back to dermatomyositis, then you initiate systemic treatment. So as you're managing these patients, this is a good table for you to run to remind you of the things that you expected to do. So in conclusion, if someone needs to know what is the main idea in this condition. One, it is an autoimmune condition that affects both the muscles and the skin. Two, it is due to autoantibodies that affect the endothelium of the capillaries that supply blood vessels to muscles. Then three, the exact cause of this is not known. However, there has been an association with particular genetic components, especially in the juvenile type, and malignant constitutions, especially in the adult type. Then four, this condition, when detected early, you have to treat aggressively with immune modulators, including corticosteroids and drugs like either thioprine, methotrexate, cyclosporin for long-term treatment. Then these patients are followed up and screened for malignancy. And then lastly, you have to remember is that this is your patient forever and ever. So you have to follow up, and other modalities like physiotherapy are key in improving the quality of life. Sun protection is a must since the sun exacerbates the condition. That's why you have a rash that is heliotropic. And you have to remember the signs that we usually elicit in dermatomyositis, including the Gottron papules on the dorsal surface of the hands, then the Gottron sign, which is just basically erythema on the dorsal surface of the hands, around the elbows and knees, then the shoal sign, if the rash goes all the way back up to the shoulders and back, then the V sign, if the rash is on the chest, heliotrope sign, if they have periorbital swelling and edema with erythema, then Holster sign when they have a rash on the lateral sides of the thighs. So that summarizes it for you. And I thank you for your attention and hope you learned something today. So lastly, as we conclude, this picture summarizes what we've been talking about. Just remember proximal muscle weakness in case you have systemic involved. It is proximal muscles, but as well, it can affect muscles of the neck, including the tongue. You see that. Then we have involvement of around here where we have the Gottron papules. Sometimes you can even get it can affect the nails. Then you get rugged cuticle. Then you have here the shoal sign. Then you have heliotrope sign here. Then you have shoal sign here. And then some patients also end up with rheumatoid phenomena. And sometimes we can have scalp lesions which look like seborrheic dermatitis, and sometimes you can have rashes on the extensors, which will make you think about psoriasis. So all those are good differentials, but dermatomyositis clinically is there to make a diagnosis. Thank you very much for your attention, and I would encourage you to comment, share, and subscribe to the channel for more interesting videos about skin in the Black population. God bless you. I'm Dr. Abraham.